So now we turn to management. And of course, treatment is, the states will direct the treatment, obviously, and for stage 1 cancers, they will go to surgery and will not require anything else. In stage 2, we sometimes follow surgery with chemotherapy, and we'll go into that in a little more detail. On stage 3, it's clear that chemotherapy can offer some benefit after surgery. And then in stage 4 disease, really the mainstay of the treatments are going to be chemotherapy, although they occasionally have surgery. And so, of course, surgery is the mainstay, really the most important for stage 1, 2, and 3, and really the only way of curing people of this cancer, where you want to completely remove the tumor, of course, and the major vascular pedicle, along with the lymphatic drainage basin. And this is really where rectal cancer, we have a little bit of a different approach, because there you have to incorporate radiation that can really help improve the cure rates. And here we do that neoadjuvantly, meaning we give them chemoradiation before surgery. And so the tumor location will of course, direct the type of surgery you do for this. So it's on the right side, a right colectomy or an extended right colectomy, possibly where you take the middle colic artery as well, if it's in the hepatic flexure. If it sits high in the left colon, you could do a left colon resection or a left colectomy, and then for a sigmoid tumor, it's a sigmoid resection. So if people have stage 2 disease, meaning they have a T3 or a T4, but it's not involving the lymph nodes, as a group, as a whole, they have not been shown to benefit from adjuvant chemotherapy. But when we divide that group down by whether they have factors that are associated with a higher rate of recurrence, we can improve their survival probably by about 3 to 5% by giving them 6 months of chemotherapy. And those high-risk factors are having a T4 tumor where it's grown through the entire wall, having lymphovascular invasion, or less than 12 lymph nodes removed, or presenting with obstruction and perforation. And clearly, the more risk factors you have, the higher the risk of recurrence, the more likely you are to benefit from some adjuvant chemo. Then in the management of stage 3 disease, obviously surgery is the most important, but here we have good data to show that giving chemotherapy after surgery can really help improve cure rates. So we talk about that about 60% might be cured by surgery alone. And then if we give chemotherapy, we could cure an additional 15 to 20%. And really the most important chemo drug is our 5-fluorouracil drug. But in 2004, the Mosaic trial did show that oxaliplatin adds to that. So now it's standard of care to give them 5-fluorouracil with oxaliplatin. And then there are always those who are going to recur no matter what we do. And really the problem is that we don't really know who is going to benefit from chemotherapy. So we, of course, give chemotherapy to everyone who can tolerate that. So for stage 4 disease or metastatic patients, again, chemo is then really the most important, the mainstay of treatment. And it is our 5-fluorouracil drug, and we pair that either with oxaliplatin or irinotecan, and that's given every 2 weeks. And we continue that for as long as we see that it's efficacious in maintaining the cancer and the patients are tolerating this okay. The toxicities vary a bit with the treatment. So with our 5-FU oxaliplatin combination, or FOLFOX is the acronym, we can see cold sensitivities and neuropathy that patients can develop after a few months of treatment, and can sometimes limit the amount of oxaliplatin we can give. With our 5-FU with irinotecan, the side effect we worry about most is probably diarrhea, and then that therapy can cause some hair loss as well. And then in the last 10 years, we have had several targeted treatments that have been approved when they are added to chemotherapy. And keep in mind that if you have someone who has only liver metastasis and no other disease sites, then occasionally those patients can really benefit from surgery, liver surgery. And I have a slide a little bit later on those patients. So these are, this is our chart of therapies for metastatic colon cancer. And 5-FU has sort of been the most important chemotherapy drug, and was really the only drug we had up until about 2000. And you can see that average overall survival is charted here in months. And back in the 80s, people were living less than a year with this, but today people are the average survival or median survival is about 2 to 2.5 years. And that is due to the addition of all these new drugs. So irinotecan we've been using since around year 2000, and same for oxaliplatin. Capecitabine is an oral prodrug of 5-FU, and so if people don't want to use the IV drug, they can take these pills. And then we've had these targeted treatments added on, and you know, really moved the curve here from the late 1990s up to now, moved the survival curve upwards. So the targeted therapies, you know, they mainly target two pathways. One is the vascular endothelial growth factor pathway, and bevacizumab or Avastin is the drug that came on the market first. And it's important to give this with chemotherapy. It does not work by itself, but these drugs can have different side effects where they cause hypertension, proteinuria. They can increase patients' risks of thrombosis and bleeding, and occasionally cause bowel perforation. So they're not benign drugs, but they do add to the benefit of chemotherapy. Then we have our epidermal growth factor receptor monoclonal antibodies. And it's important to note that if the tumor has a mutation in the KRAS or NRAS gene, that these drugs are then not effective and should not be added to chemotherapy. And these drugs can by themselves have some effect in shrinking the tumor, but they work better if you combine them with the chemotherapy. And they can cause acne and diarrhea, and cetuximab can occasionally cause infusion reactions. Then we have our immunotherapies, our program DEath1 inhibitors, now 2 on the market, pembrolizumab and nivolumab, for the indication of colorectal cancer with this MSI high phenotype. So it definitely does not work for all colorectal cancers, but in the 4% of metastatic colon cancers that have mismatch repair deficiency, where they're lacking one of these 4 proteins, you know, this therapy can really benefit those patients. And when you have mismatch repair deficiency, that really causes the tumor to develop a lot of mutations. But the tumor cell is smart, and it will express something called PD-L1, and that will stop the immune cell, the T cell, kind of in its tracks. Because this tumor cell, because of all these mutations, you know, it looks quite a bit different from our normal healthy cells. And so if we give a PD-1 antibody and break up this bond, the T cell can become activated and attack the tumors. And this was a pivotal trial in the New England Journal of Medicine in 2015. And this looked at mismatch repair deficient colorectal cancer cases. These were patients who had been heavily pretreated, had metastatic disease, of course, and they gave them pembrolizumab, and the disease control rate, meaning the likelihood of having either a partial response or stable disease on therapy, was 90%. And this is you know, sort of remarkable in our world of oncology dealing with metastatic disease. And the median duration of response was not reached. And in fact, most of the patients who've had a response to this therapy have not yet progressed. So we're years out now. And then after we've diagnosed someone and resected them, it's important to do surveillance. And here we follow patients for 5 years. And that's because for the people who are destined to recur, almost all of those recurrences will happen within those first 5 years. And in fact, the first 3 years are most important. But so we bring them into our clinic every 3 months for the first 2 years, and then every 6 months for the next 3 years, do a physical exam and do blood work, including that tumor marker, the CEA. And then they get a colonoscopy about a year after diagnosis. And then in 3 years, if everything's normal. And then our guidelines also recommend CTs of the chest, abdomen, pelvis yearly for 5 years.